My name is Devane. I hail from Wellington in New Zealand, which is currently a long way away in 9 hours time difference. I'll just give a talk outline, and that is that the PROMS data that I'm going to share with you is out of the New Zealand Joint Registry. We're the only ones that started collecting it from the inception of our registry in 1999. And I'd like to just discuss for a few seconds why we added PROMS, what they do, what the results of the PROMS data are, some of the uses that we're starting to see in New Zealand, and then perhaps draw a few conclusions. The New Zealand Joint Register was established by Alistair Rothwell in 1999 after he had been the president of the New Zealand Orthopaedic Association, and it was 1997 when he was president, and it was 30 years since the first hip had gone in New Zealand. It is a paper-based registry where the individual pieces of paper for a primary total joint replacement are filled out in the theatre, transported down to Christchurch where the registry is based, and then put into the database. The compliance in the New Zealand registry we're very proud of, because it's been almost into the legislation where, in order to achieve our annual practicing certificate, we have to sign a piece of paper saying that we must contribute to the registry. And cross-checking with implant companies and with the New Zealand Health Information Service, we think we've got closer to a 99 than a 97% compliance. Why did PROMS get added in 1999, right at the beginning of this whole business? Well, I think we as orthopaedic surgeons only see in certain instances what we want to see, and that is the results of a lovely looking x-ray we assume will mean that a patient is very happy, but we all know in reality that that may not be quite the case. So I'd like to illustrate that with my only x-rays in this set of slides, and you can see that this particular x-ray shows preoperatively quite bad arthritis in both hips. And classically, post-operatively, they had a randomised trial with a cementless on one side and a cemented on the other. But the post-op x-ray really only shows the inside of a total hip replacement, and we've all seen lots of x-rays and will continue to do. But what about the outside of the x-ray, outside of the patient? And I think this slide sums up why PROMS are so important, and I'll read it out for you. I can't say I'm entirely pleased with my total hip replacement. So just keep in mind that the PROMS really represents the patient's view of their hip replacement, which may not agree with their x-ray. Patient-reported outcome measures really have emanated out of the Oxford unit, where the Oxford hip score was the main measurement tool that we adopted in 1999, and we're beholden to Andy Carr, who's actually given the plenary lecture earlier today. The Oxford hip we've modified slightly to a score of 48 being the 0 out of 48 being the worst, up to 48 out of 48 being the best. And there's 12 questions with 4 potential answers. And we've also used what's called the Kalaraja grading to make it simplified, which is when you break up the 0 to 48 mark, you can see that a score of greater than 33 indicates that the patient has a good or excellent result as perceived by them filling the forms out. 20% of all of the hips done in New Zealand have been sampled by patient-reported outcome measures. That means that of the 93,000 odd patients in the New Zealand registry, 26,000 have 6-month PROM data, nearly 8,000 have 5-year PROM data, and 5,000 have 10-year PROM data, and you can see that the good or excellent results of a score, Kalaraja score greater than 33, are maintained, if not improved, with the increasing life of the implant. Most patients, we can conclude then, are very happy with their hip replacement, and that result persists for the 5 and the 10 year. Within the individual questions, we've analysed some of that, and we find that the most common problem with the 6-month poor PROMS data was limp, which is question 10, and that the 5 and the 10-year problem was more to do with pain, but those tended to even out again over time with more advancing time. Now, what about answering the question, one more slide, and that's on revision total hip replacement, where all revision procedures, including patients with hips implanted before 99, were sent Oxford hip scores. And this is just a slide showing that although revisions are often good, they're not as good as primary total hip replacement, with only 65% of the 6,800 respondents getting a Calaraja grading greater than 33%. Now to come on to the primary question, can we use this data to predict the risk of revision of total hip replacement? I'll spend a second or two on this slide because this slide has the 4 categories of Calaraja, and remember that less than 27 are the unhappy patients, and you can see that there aren't very many of them when you look at the total number, but a lot of those people then end up with a revision within 2 years of them filling out the 6-month Oxford hip score. And then that falls off to a much smaller number for the good and excellent results. And if you do what's called a receiver operating curve analysis, a score of 38.5 has 5 times the risk of needing a revision compared to a person with a score greater than 38. And 70% of the revisions within 2 years occur in people with the lowest 32% of Oxford hip scores. This is the risk of revision at 5 years. The slides are laid out in the same numbers on the graph, and you can see that this result is consistent at 5 years, and this includes those patients that have already had their revision within 2 years from the first 6 months Oxford hip score. So you can see again that the poor Oxford hip score has a very good predictive value of approximately 6% for predicting the risk of revision within 2 years, and the very good or excellent results have a very good predictive value that they won't need a revision. This is the same slide from the 10-year Oxford hip score, and again you can see that the numbers actually go up. You're now looking at over 9% of patients with a poor Oxford having a revision within 2 years of filling out their 10-year Oxford hip score. And you've got to remember, and I keep reiterating that you've already taken out all of the revisions for the preceding Oxford hip score. So for the 6 month data and the 5-year data, those revisions within 2 years have been removed when we look at the 10-year data. So it really is a very good predictor of revisions. And this is just a graphic to show that with the top slide being the poor, that actually where you go to the 6 months data, the 5-year data and the 10-year data, you can see that those diverge, which means it actually becomes more predictive with the 10-year data than with the earlier stuff. And just one last slide on the revision hip replacements that have all filled out their proms, and this is the revision predicting a risk of a re-revision. You can see that nearly 24% of people who have a poor Oxford hip score will have another revision within 2 years of their first revision. And that compared to primary total hip replacement is almost 4 times as much as the 6 month data. So all right, using proms for follow-up. Well, 70% of hips revised within 2 years would have been captured by monitoring the lowest 30% of Oxford hip scores. And using the 5 years, 73% would have been obtained within 2 years of the lowest 30% of the Oxford hip score. Many New Zealand hospitals now use proms for waiting list prioritisation to decide who will get surgery ahead of someone else. And the largest hospital in New Zealand is using it instead of routinely setting their patients after the 1 year mark. I think we can conclude that from a patient's perspective, total hip is a very successful operation. But if a patient is not happy with their total hip replacement, they have a much greater chance of ending up with a revision. And I think we can conclude that the outside results, remembering the zebra of a total hip replacement, are just as important as the inside results. Thank you for your time and attention.